In this video, I will be discussing about a topic that you will miss to read while preparing for your medicine university exam in the chapter Infectious Diseases, and that is leptospirosis. Leptospirosis is a very commonly asked, long question in your university exams. So let us discuss leptospirosis under the following headings: a basic introduction, what is the etiology agent, epidemiology, what is the clinical features, how will you diagnose, what is the treatment, what is the chemoprophylaxis, and what is the prognosis. So remember, leptospirosis is a globally important zoonotic disease, okay? And recent years it has been found that there is re-emergence of these group of diseases. Most of the cases of leptospirosis will be in its mild form, and very few cases only present as the so-called severe form of leptospirosis, that is, we call it as Wheels syndrome. And the mild leptospirosis usually present as a fever, headache, and myalgia, whereas the severe leptospirosis is characteristically presented in the form of a triad of jaundice, renal dysfunction, and hemorrhagic diathesis. Okay, that is what we call it as Wheels disease or Wheels syndrome. So as you all know, the major pathogen is Leptospira interrogans. Okay, that is actually the spirochete that is responsible for leptospirosis. And as you all know that leptospires are coiled, thin, highly motile organisms. Okay, they have hooked ends. They have something called as periplasmic flagella. Okay, and these periplasmic flagella with certain extrusions, okay, some certain projections from the cytoplasmic membrane that is responsible for the motility of the leptospira. This is not just about leptospira. For all the spirochetes, we have something called periplasmic flagella that is responsible for the motility. And as you all know that since it is a spirochete, it can be observed through dark field examination. So coming to epidemiology, as I told that leptospirosis is a zoonosis. Okay, so it affects almost all mammalian species, and out of that, the most important reservoir, which is a very commonly asked question, what is the most important reservoir in leptospirosis? The answer is rodents. So when it comes to leptospirosis, about the epidemiology, either it can present as an endemic disease or an epidemic disease. Okay, because as I told you that the transmission is mainly through direct contact with the urine or blood or tissue from an infected animal or through environmental contamination. So it can present as an endemic as well as an epidemic. But Leptospira epidemics, the transmissions are not well understood, okay, in literature, but endemic transmission of leptospira is very common. And another important risk factors as mentioned here, it includes direct or indirect contact with animals, including exposure to water, soil contaminated with animal urines, and certain occupational groups are at high risk. For example, veterinarians, agricultural workers, sewage workers, slaughterhouse employees, and workers in the fishing industry. So these are the risk groups. So coming into the other, risk groups, one is recreational freshwater activities doing persons such as canoeing, windsurfing, swimming, and water skiing. Okay, these areas have very high risk of infection. So please remember, so all these are the risk factors for leptospirosis. So I hope you understand by this time that how common is leptospirosis. Yes, I am from Kerala. In Kerala, we have very high incidence of leptospirosis in these areas. That means especially in these areas with recreational freshwater activities, swimming, water skiing. Okay, because those are unhygiene. Yeah, fine. Then remember, it is also a traveler's disease. Okay, traveler's disease, especially in tropical countries, especially those who are doing adventurous activities such as whitewater rafting, jungle trekking, okay, caving, all those things. Fine. So then coming into the pathogenesis. So as I told you that the transmission mainly occurs through the cuts, abraded skin or mucous membranes, especially through the conjunctival and oral mucosa. After entry, the highly motile organisms, we have the periplasmic flagella, which is present in the spirochete group of organism that will help the organism to move, cross tissue barriers, and disseminate hematogeneously through the blood to all the organs. That is called as a leptospiremic phase. Okay, leptospiremic phase. So that is why why this leptospirosis is so dangerous, because it is blood spreading infection. Okay? It is actually an infection of the blood. Once it enters the blood, it can spread to any organs. Fine. And remember, leptospira can evade our immune response by preventing complement-mediated killing and phagocytosis. It inhibits the phagocytosis, and that is why it keeps on proliferating. And mainly, it affects the kidney in the form of acute tubular damage and interstitial nephrosis, and it can also cause damage to the liver. That is why it causes jaundice. Okay, that is hepatocyte apoptosis is also well established. And another one thing is a lot of electrolyte disturbances. Okay, electrolyte disturbances because of the kidney failure. It also occurs in the case of of Weil's disease. That is a severe form of leptospirosis. So this is actually, you can see here, the incubation period will be like 2 to 30 days, and we have something called as an acute stage, which usually present with a fever and myalgia, which is like a non-specific symptoms. Then there will be a convalescent phase, and finally even later, okay, suppose if they are carriers, they can even have uveitis and interstitial nephritis. Okay, fine. So we have just two phases. Remember, one is the acute stage, and then we have the convalescent stage, and sometimes some of them can be so-called as the convalescent carriers. Okay, fine. And so usually in the first weeks and all, we use either blood or urine, and rest of the time urine is the major source of doing culture and all other investigations. Fine. So incubation period, as I told you, it is usually 1 to 2 weeks, but it can range from 2 to 30 days, and it is actually a biphasic phase. One is the leptospiremic phase, which is characterized by fever of 3 to 10 days duration, and in that time the organism can be cultured from the blood. Okay, and during the immune phase there will be resolution of the symptoms, and that is why I call this so-called as the convalescent phase. Okay, in that phase only antibodies can be isolated. But see, antibody detection has almost nil role in the diagnosis of leptospirosis. So coming into the clinical features, so remember, petechiae and hemorrhages can be observed in the heart, lungs, kidneys, pancreas, liver. That is so-called as the bleeding, hemorrhagic manifestations. Then the patient can also end up in consumptive coagulopathy, that is so-called as the disseminated intravascular coagulation. And so let us come into the two phases. One is the mild leptospirosis and another one is the severe leptospirosis. So in mild leptospirosis, there will be non-specific symptoms of fever, chills, headache, nausea, vomiting, abdominal pain, conjunctival suffusion, and myalgia. See, this is actually one of the previous AIMS question. It is not conjunctivitis which is seen in leptospirosis. It is actually conjunctival suffusion which is seen. And remember, in children, aseptic meningitis is also one of the documented presentation. And again, physical examination, as I told you, fever, conjunctival suffusion, pharyngeal injection, then muscle tenderness, lymphadenopathy, meningismus, hepatomegaly, splenomegaly, anything can happen. And of course, mild jaundice will be present. See, jaundice is not that much appreciable unless and until it is a severe leptospirosis. Because in severe leptospirosis, the case fatality rate, the mortality rate is actually high, up to 50%. The patient may present with AMS, altered mental status, acute renal failure, then respiratory insufficiency, hypotension, and arrhythmia. And the classic presentation was so-called triad of hemorrhage, acute kidney injury, and jaundice. Okay, so jaundice because the liver is affected because of hepatocyte necrosis, acute kidney injury because of the tubular damage, and hemorrhagic manifestation because of the so-called as the DIC. The patient will finally end up in consumptive coagulopathy or overt disseminated intravascular coagulation. There will be bleeding from all the system, GI system, then subarachnoid bleeding, everything. So the patients usually die of multi-organ failure after septic shock. And as I told you, jaundice occurs only in 5 to 10% of the cases because of the fulminant hepatic necrosis. But acute kidney injury is very, very common in severe leptospirosis. Okay, yeah, and the patient usually have electrolyte abnormalities like hypokalemia and hyponatremia. Then other presentations may be either in the form of cardiac involvement, in which there will be non-specific changes in ST and T waves. There will be elevated serum creatine kinase because of the rhabdomyolysis. There will be pancreatitis-like presentation. And as I told you, all systems are involved in leptospirosis. Fine? Yes. Even myocarditis. Then coming into diagnosis, just remember the definitive diagnosis of leptospirosis is based on isolation of organism in the PCR. So as of now, only we are using PCR for the diagnosis of leptospirosis. Earlier, we used to use something called as MAT, that is microscopic agglutination test. But see, it is actually an antibody type. It is a type of heterophil agglutination test. Okay, where you used to find the antibodies titer. And as of now, it has no clinical relevance. Okay, because we can't wait for the antibodies to come in a case of leptospirosis. So we usually go for PCR, and of course, by clinical manifestations, we can find that the patient may be having leptospirosis. Okay, so MAT is actually it's a type of an antibody assay, but in the first week we always use PCR, that too blood. Then second week or in the convalescent phase only we can rely on the antibodies, and after that only we can use urine for the PCR purpose. So initially first week it is blood, then second week and all antibodies, MAT, microscopic agglutination test we can use, and the rest of the weeks we can go for urine. So coming into differential diagnosis, as I told you, the mild leptospirosis, it has non-specific symptoms, that is in the form of fever, myalgia, vomiting, okay, all those. It can resemble so-called as malaria, typhoid fever, and viral hepatitis. So it is very difficult, okay, to find that, okay, to differentiate mild leptospirosis from the so-called as mentioned diseases, that is malaria, typhoid, ehrlichiosis, viral hepatitis and all. But that's not the case with severe leptospirosis. It is very, very easy to diagnose, and of course it is fatal also. So coming into the treatment, it depends upon either it is mild or moderate to severe. So mild means definitely we will go for doxycycline. Currently we are using doxycycline only, okay, because amoxicillin, ampicillin resistance has been found. Whereas in case of moderate to severe leptospirosis, of course it is always penicillin or ceftriaxone, that is the so-called cephalosporin group of drugs. Okay, that is cell wall inhibitors. Mild leptospirosis, doxycycline. Remember, moderate or severe leptospirosis, it is intravenous, IV penicillin or ceftriaxone. And chemoprophylaxis, we can use either doxy or azithromycin. So mild doxy, severe it is penicillin or ceftriaxone. So coming into the prognosis, as I told you, most of the patients recover because if it is mild, we should not worry about the complications, okay, because there is an overlap of clinical features of mild leptospirosis with other diseases like malaria, typhoid, ehrlichiosis, viral hepatitis and all. And severe, of course, the patients very quickly respond to IV penicillin and ceftriaxone. But remember, during pregnancy-like conditions, leptospirosis, that too severe leptospirosis, have very high mortality rate. As I told you, the severe leptospirosis or the Weil syndrome has nearly 50% mortality rate. So, but that 50% mortality doesn't mean that we will lose the patient. No, the patients will quickly respond to the IV penicillin and ceftriaxone like antibiotics. And prevention, as you know, we have to be very careful, especially while involving in recreational freshwater activities. So this is just about leptospirosis. So once again, I am telling. So it is a spirochete which causes the disease, Leptospira indrogens, which has periplasmic flagella. Microscopically detected by dark field examination. Rodents are the most important reservoir. Then contamination by direct contact, urine, blood or tissue. Fishing industry, veterinarian, sewage workers, slaughterhouse employees, all are at risk. What risk factors? Then occupational groups like recreational freshwater activities, again they are at risk. Transmission, direct spread, abraded skin, acute tubular damage, interstitial nephritis, hepatocyte apoptosis. And in the first week, always remember it is blood PCR. And second week, third weeks, we can go for MAT, microscopic agglutination test. And rest of the times we can go for urine PCR. Okay, and finally the patient will end up in so-called as conceptive coagulopathy over DAC. Mild leptospirosis overlap with other features like malaria, diseases like malaria, typhoid and all. And coming into severe leptospirosis, remember it is always about the high mortality of 50%, and that is called the Weil syndrome. The classic presentation is hemorrhage, jaundice and acute kidney injury. So whatever it may be, always remember PCR. And next, coming into mild leptospirosis, it is doxycycline, and moderate to severe it is IV penicillin or ceftriaxone, and chemoprophylaxis we can always go for doxycycline or azithromycin. And prognosis, most of the patients recover. Thank you.